Hi everybody, welcome to Dr. Manny's YouTube Learnshops. This is part 3 of continuous renal replacement therapy, and this is where we look at the Gambro Prismaflex unit. And as I indicated previously, this is just a machine that I've used in my career. I'm not promoting it in any other way other than it's a really good machine, as probably all the machines are in continuous renal replacement therapy. The objectives are to review vascular access, anticoagulation strategies, again just to reinforce the previous Learnshop, and then look at Prismaflex therapy options, setup overview, components and external features. Selected. We can't do absolutely everything, so it'll give you an insight into what the Prismaflex hemofilter is all about. Venous vascular access. As I indicated previously, there are 3 main access sites for placement of central venous catheters utilised for CRRT. This is the subclavian vein, the internal jugular vein and the femoral vein. And typically you can have a curved or you can have a straight catheter. Straight catheter is more user-friendly for femoral access. The curved catheter is more user-friendly probably for internal jugular and subclavian vein. Subclavian vein seems to be the most recommended. The access devices, as I say, I'm not promoting them for any other reason, it's a physician preference. So no recommendations are being made here, and typical sizes in the newborn are 6.5 French, child 8.5, adolescent or adult greater than 11 French. When it comes to vascular access devices, as I said, it's a physician preference. Typical sizes are as has been stated previously. However, take note, it's the vascular access device that typically causes more than 90% of the troubleshooting problems. Kinking, blocking, flow, incorrect connection. Anticoagulation options, as discussed previously, we'll just reinforce again. You don't have to use it. Maybe you can't use it. Maybe it's contraindicated. Citrate can be used, heparin can be used. This can be unfractionated or it can be low molecular weight. Prostaglandins, 1 or 2 can be used. R-Huridin can be used or danoparoid could be used. It's a medical decision and guided by protocols for your specific hospital and intensive care or critical care area or renal unit. Now when it comes to the Prismaflex, the therapy options can include SCUF, CVVH, CVVHD, CVHDF, PTE, HP, slow continuous ultrafiltration, continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, continuous venous-venous hemodiafiltration, therapeutic plasma exchange, and hemoperfusion. They're the therapy options, the main ones. So let's review SCUF from a Prismaflex perspective. And again, this is just an overview. So SCUF is slow continuous ultrafiltration, and it's for all the intended uses we mentioned previously: diuretic resistant fluid retention, pulmonary edema, which can be cardiogenic or pulmonic. Treatment parameters: the blood flow rate can go from as low as 10 to 450 mL per minute. It can have a pre-blood pump solution from 0 to 2000 mL per hour, and a net fluid removal from 0 to 2000 mL per hour. When it comes to the priming of the circuit, there's always a normal saline priming solution with or without an anticoagulant. Typically now without an anticoagulant such as heparin, because of things associated with HITS, heparin-induced thrombotic thrombocytopenia syndrome, certainly in the critically ill patient. So follow the numbers. 1, the priming solution of normal saline, which is connected to the access line and the effluent line, and it primes. It drains into the effluent bag too. You've also got a pre-blood pump solution 3, and it's associated with the venous line and the effluent bag. It primes and gets rid of all the air or anything in the circuit that is not wanted. The patient connected to SCUF is now connected to the effluent line and the drainage bag. 1, red, is the access line, 2, blue, is the venous line. And they are now connected to the patient because the circuit's primed. So the circuit essentially consists of access line red, return line blue, in between the hemofilter and connected to the effluent bag. And that removes the fluid that you don't want in the patient. Now when we look at CRRT, continuous vena-venous hemofiltration, the intended use is almost the same. Acute kidney injury, which can be associated with renal insufficiency, failure, life-threatening homeostatic situations such as electrolyte imbalance or acid-base disturbances, septic mediators, cardiogenic and pulmonogenic pulmonary edema. Treatment parameters are typically the same. However, in hemofiltration we have pre-filter and post-filter replacement rate. And pre-filter we can give at 8,000 mils per hour, post-filter 6,000 mils per hour. When it comes to the priming, it's basically the same. However, we have a replacement solution now. So 1, normal saline is the priming solution. This will prime the access line and the effluent line because they're connected to the priming Y connector, which we'll be reviewing when we look at adjuncts in Learnshop 6. It's connected to the effluent bag, which it drains into, number 2. The pre-blood pump solution 3 is connected, and the venous line is connected to the effluent bag, and the replacement solution replaces or primes that line as well, which also drains into the effluent bag. After which the patient is connected to CRRT, the effluent line is now connected to the effluent drainage bag, so yellow to yellow. The access and venous lines are now connected to the vascular catheter because one's going to pull blood out of the patient and one's going to return blood to the patient. The access line, the dirty blood, for want of a better term, and the clean blood back to the venous line. So essentially what you've got is access line from the patient, pulling blood out, negative pressure, through the hemofilter, cleaning or doing whatever it's supposed to be doing, and returning it to the patient. The effluent collects the fluid and the contaminated fluid with the waste product. The replacement is now diluting the blood, and this can be given pre-filter or post-filter. Some clinicians prefer to give it pre-filter because it dilutes the blood a little bit, making it less coagulate. Others prefer to give it post-filter, putting it directly into the blood as it goes into the patient. Then you've got CRRT, continuous vena-venous hemodialysis. Intended uses are basically the same. Parameters, blood flow rate is similar, if not the same, 10 to 450 mils per minute. Dialysate rate is 8,000 mils per minute, up to. Net fluid removal can still be up to 2,000 mils per hour, and the pre-blood pump can be used, if wanted, up to 4,000 mils per hour. So when it comes to priming, again, similar, but now we have a dialysate solution, not a replacement solution. So normal saline is the priming solution. It's connected to the access line and the effluent line via the priming Y connector, and it drains into the effluent drainage bag. The venous line is connected to the effluent bag. The pre-blood pump solution is also connected, 3, and there is a dialysate solution. It primes the whole circuit. Now, if we're connecting the patient, the effluent line is connected to the effluent bag again, and the access line and venous lines are now connected to the patient's vascular catheter. So what we have, patient access line connected to the filter, return line blue. However, we have the effluent bag that collects the fluid and the dialysate which delivers the fluid. CVHDF, continuous veno-venous hemodiafiltration, does everything now. It does hemofiltration, it does dialysis. Intended use is essentially the same, but it offers you everything, and the whole circuit is primed. So during priming, normal saline primes the circuit. Access and effluent line are connected to the priming Y connector, as with all the other therapies, and they all drain the fluid, air, any sterilising contaminants into the effluent bag. Typically, 2000 mils is used as priming solution in most priming setups. You've got the dialysate solution connected, 4, replacement solution connected, 5, pre-blood pump solution connected, also referred to as the substitute. The venous line is connected to the effluent bag, so everything drains into the effluent bag. The access line is doing its job, pulling the priming solution, going through the whole circuit. The venous line is doing its job, returning all the priming solution into the drainage bag. Once the patient's connected to CVHDF, the effluent line is now connected to the effluent drainage bag, yellow to yellow, and the access and venous lines are now connected to the vascular catheter, which is the patient. So the circuit essentially is red access line, pulls blood out of the patient to be cleaned in the hemofilter, then is returned to the patient. But before it's returned to the patient, it goes through the dialyzer. The dialysate solution pulls off things like urea, creatinine. If the potassium is high, the replacement solution dilutes. It dilutes the blood, and in doing so, the pump automatically will pull off more fluid. And in doing that, you have blood purification. Now, therapeutic plasma exchange is another therapy that can be initiated by Prismaflex, but it needs a different set, completely different set. And therapeutic plasma exchange is essentially plasmapheresis. So you're exchanging plasma, contaminated plasma, maybe with autoimmune contaminants, with clean plasma. And the intended use is to remove pathogenic, non-bound plasma proteins. So the circuit is similar to this. It's not a hemofilter, it's a plasma filter, and it has an effluent bag which puts the contaminated plasma into it. The replacement solution will be uncontaminated plasma. Hemoperfusion is another therapy that can be initiated by Prismaflex, and this is using the principle of adsorption, which we discussed earlier. And this is where you get the removal of pathogenic, non-bound plasma proteins. They stick to the semipermeable membrane. And this is where endotoxins, such as inflammatory mediators related to immune complexes, can be removed. It requires another circuit, and it has a hemoperfusion cartridge in which now the toxic substances adhere to. You still have the same similar setup, in the sense you've got an access line which goes to the cartridge, which is not a hemofilter, it's a hemoperfusion cartridge. And then you have the return line which goes back to the patient, where you've got contaminants adhered to or adsorbed to the filter. And at the same time you've got the infusion, and the infusion essentially is fresh plasma. Now let's review the Prismaflex unit itself, and not in a lot of detail, but just to give you an overview as to how this machine functions. The front view, you've got status lights, a communication display. The middle has got a set barcode reader, filter holder, pumps, pressure transducers, air detector, blood lead detector, return line clamp and syringe pump. And the bottom are the scales, the base stand, the wheels and the brakes. The status lights basically tell you the status of the machine, and this is located at the top of the unit, and it indicates the operating conditions, which can be green, which is normal run mode, yellow, which is cautionary or advisory alarms, and red, which are warning or malfunction alarms. The communication screen is really just a monitor, and it shows you the information very, very clearly, and it's nice in the sense that it's got a touch screen display. So it allows you to navigate very easily through the screen to the things that you want to do. For example, here you've got loading the set. And once you've got things in place here, it automatically loads the set once you touch screen the load. If you've got any issues, you can press the help button and it will help you and give you instructions. Then you've got the barcode set detector, and the function of this is a safety feature that it recognises the type of filter set that you're going to employ, so that you're going to use the right therapy in the setup and the right filter for the therapy that you're going to initiate. Here is the machine, and this is where once you put the cartridge in, this is where it senses. And it senses the barcode. It either passes or fails. Then you've got the filter cartridge carrier, and this automatically loads the set into the pump raceways. It does it automatically. You don't help the machine. If you help the machine, it usually ends up being problematic. The machine will load this all by itself, and this is where it's located. The filter cartridge fits here, and it automatically puts the pump raceways into the correct position. Then you've got the pumps, and you've essentially got 6 pumps. You've got the blood pump, the effluent pump, the pre-blood pump, the dialysate pump, replacement pump and the syringe pump. Now the blood pump generates the blood so it's moving. The effluent pump pulls out fluid and puts the fluid into the effluent bag. The pre-blood pump puts in replacement solution or substitute solution before it goes into the blood, diluting the blood. You can have dialysate solution and replacement solution and a syringe driver as well. The syringe driver would be for heparin. Now when it comes to the blood pump, this is a peristaltic pump. It pulls dirty blood, and I'll use the term loosely. It's blood that you want to remove certain products from, whether it's urea, creatinine, potassium, toxic products, and so on. It pulls dirty blood out of the patient, pumps it through the filter set blood path, and therefore cleans the blood, and then returns it to the patient at a blood flow rate from 10 mils to 450 mils per minute. That's the blood pump. Then you've got the effluent pump. The effluent pump is in the upper left-hand corner as we face the machine, and it controls the ultrafiltration rate, removing ultrafiltrate, dialysate, which includes the patient fluid, replacement fluid, dialysis fluid, pre-blood pump fluid, and the maximum flow rate can be 10 litres per hour that can be removed. The pre-blood pump pumps fluid into the blood path. This can either be done pre the filter or post the filter. and the maximum flow is approximately maximum 8,000 mils per hour. You've got the dialysate pump, and this pumps dialysate into the fluid compartment at a flow rate of about 8,000 mils per hour maximum. Depends on how quickly you want to remove the product. So for example, if you've got a patient who's got hyperkalemia and you want to remove the potassium really quickly, you would have a high flow rate. If you've got urea, you may not want to remove it as quickly, because removing it too quickly may cause cerebral edema as a consequence. Then you've got the replacement pump, and this is a pump that pumps fluid into the blood path either pre or post filter. Maximum flow rate 8,000 mils per hour. It depends on the situation that you're in and what you want to remove or dilute or purify. The syringe pump, this is to deliver the anticoagulant. This can be done either continuously or intermittently. Depends on the physician order. You've got pressure transducers. And the pressure transducers that you've got are the one on the left hand side, and this really doesn't do anything currently, it's for future therapy. Then you've got the return pressure transducer, which measures the return line pressure. The effluent pressure transducer, which measures the pressure created to create the effluent. You've got the pre-filter transducer, which determines how much pressure it requires to deliver the pre-filter fluid. And you've got the access. And the access transducer tells you what sort of negative pressure you're creating to pull out the fluid. And these are all in conjunction with the different pumps that you've got, which the four that you can see. Pressure transducers indicate the pressure, positive or negative. And sometimes, depending on the therapy, it can be positive or negative, especially the effluent. Typical pressures are these. So the access pressure is negative because it has to pull blood out of the patient, the red line. The filter pressure is the positive pressure because it's got to push the blood through the filter. It will be positive. The return pressure is positive as well because it has to push blood back into the patient. The effluent pressure can be positive or negative. It depends on which therapy is being initiated. Typical pressures range from 50 to 150. So the return pressure is typically 50 to 150 millimeters of mercury. The access pressure is 50 as well, but it's negative. Minus 50 to minus 150. The filter pressure is always positive, as we said, plus 100 to 250. And the effluent depends. It can be more than 50 or it can be less than 150. What are some of the safety features associated with the Prismaflex? Well, you have an ultrasonic air detector, a blood leak detector, a deaeration chamber, a discharger guide ring, and a return line cramp, which we'll explain. Now, the ultrasonic air detector detects air just before blood returns to the patient. So therefore, this prevents catastrophic situations which could result in an air embolism. But it also detects dislodgement of the tubing and blood in the line, even though it's not the blood leak detector. So if the tubing isn't in the correct place, it will alarm and alert because it's detecting air, I guess. The blood leak detector is an infrared detector that monitors for blood in the effluent line continuously. Any blood detected, it will alert. Then you've got the deaeration chamber, which promotes air removal continuously, and in doing so, stops bubbling. Air in the chamber can cause bubbling, and this may prevent clot formation. In the deaeration chamber as well, it's important that you maintain the correct air and fluid level, because again, this prevents bubbling or foaming, and in doing so, it obstructs blood flow. And if it obstructs blood flow, clots can form. So it's important that fluid levels are maintained as per the recommendations. There's a good example of where the fluid level should be, and there doesn't seem to be any bubbling there at all. So maintaining the correct blood level may prevent bubbling or foaming and clots forming. Then you've got the discharger guide ring, and this is important because it can minimise electrostatic interference. And electrostatic interference can interfere with other aspects related to what you're doing with monitoring for a patient. The return line clamp is another safety feature that clamps and blocks the line, blocks blood returning to the patient, and it stops all the pumps when red alarms are activated. So if a red alarm is activated, all the pumps stop and the return line clamps down and will not let anything move forward into the patient. When we look at the bottom of this machine, the scale components, you have the effluent, pre-blood pump, dialysate and replacement. So there are 4 scales that are constantly measuring the volume. And essentially what goes in should come out. So if you've got fluid, a litre goes in, then there should be a litre in the effluent. You've got a scale carry bar which makes it easier for you to move fluids around, and this is what your fluids hang on. And it's a component of the scales. The base components also consist of 4 wheels and 1 brake. And this is important because you want the machine to remain stable and static and not moving around. You've got effluent bags, and these come with Prismaflex either in 5 or 9 litres. On the side view, you've got the power switch, and you've got a connection for the Prisma therm heater. We'll be looking at these in a little bit more detail in a subsequent Learnshop. On the rear view, you've got the AC power cord socket, the power cord holder, the manual pump crank and the Ethernet port. And the manual pump crank is really important because again you may have to do a manual return of the blood if there's a power failure and the battery backup isn't effective. So you can always return the patient's blood either automatically, electronically with the machine, or with now the manual return blood handle crank. So let's review. Can you name the 3 status lights and their location and their functions? The status lights are at the top of the unit. They indicate operating conditions. Green means normal run mode, no problem. Yellow, cautionary or advisory alarms. Red, warning, malfunction alarms. What about, can you explain the function of the barcode detector for Prismaflex? The function of the barcode detector is to make sure that the machine recognises that the type of hemofilter set actually belongs to it. Because believe me, you can put different sets into different machines. I don't know how, but it has happened. Can you name the 6 pumps in the Prismaflex unit? The 6 pumps are the blood pump, the effluent pump, the pre-blood pump, the dialysate pump, the replacement pump and the syringe pump. What about the importance and function of the syringe pump for Prismaflex therapy? What is it? Well, the syringe pump is important to deliver anticoagulant, and this can be done either continuously or intermittently. Review activity 5. How is air detected in the Prismaflex circuit? Well, air is detected with the use of an ultrasonic air detector, which is located in the return line. And it also detects dislodged tubing and blood. But it's in the return line before blood goes back to the patient to avoid air embolism. Okay, this is the last review activity. Name the safety feature which activates when a red alarm is triggered in the Prismaflex unit. The safety feature which is triggered is the return line clamp. And this activates when you've got a warning or a malfunction alarm, a red alarm. And it stops all the pumps when the red alarms are activated to prevent anything bad happening to the patient. Okay, so in conclusion, Prismaflex CRRT is a strategy for acute kidney injury in critically ill patients, as it not only removes waste products but other molecules such as cytokinases, which are toxins, and are targeted for removal especially in septic patients. The therapy options that were reviewed were SCUF, CVH, CVHD, CVHDF, therapeutic plasma exchange, TPE, and hemoperfusion, HB. The Learnshops Part 3 also introduced learners to some of the important features of the Prismaflex unit. So go to CRRT Learnshop Part 4 and it'll provide additional information which relates to set availability and software features. Thanks again for following me, Dr. Manny, in this Learnshop. This is the end of Learnshop Part 3. Now, if you think it's been of any value to you, please recommend it to your colleagues, your friends, your associates. Subscribe and review Part 4. Thanks. See you next time.